Wolf, may I ask a question?
Sure.
Salvador, and perhaps even Anne, that you're with us, it's an inflammatory syndrome. The dexamethasone component early on impacts the evolution of cytokines and an inflammatory syndrome. And yet later on, it becomes detrimental, evidently, to continue with the dexamethasone or steroid treatment because one now does not want to mute otherwise the responsiveness of the host to the virus. Perhaps you would make some comment regarding the endothelial observations that you made with the receptors, but as well a component regarding the inflammatory syndrome, cytokines, interleukin 6, etc. And I also, if I may ask that question of Anne as well. But Salvador, your initial comments, please.
Yeah, well, the steroids you would expect them to have this double H effect, protective at some point, and then deleterious because of the reasons you mentioned. I don't know at this stage what is the clinical protocol and at which stage of the disease is being used, because the trial in London was used late in the disease rather than early. And I don't know if the use earlier would have a better protective effect or not. This is a question that I don't know how to answer at this stage, because we don't know exactly how the sequence of the cytokine storm takes place. But my impression would be that probably the earlier use of glucocorticoids might afford a better protection than the later one. I don't know what.
And can you make a comment to that, please, as well?
Sure. So I find this very interesting because I don't think we understand why dexamethasone had this impact when we haven't seen it on other agents that do impact the cytokine storm, right? And so when we know IL-6 inhibitors such as tocilizumab, sarilumab, et cetera, have not shown any benefit in multiple trials, both looking at late disease as well as mild disease. And so it's very interesting why then receive for dexamethasone. And, as Salvador says, I agree the fact that you would think that it would work earlier. However, the recovery trial showed us a greater impact when they were intubated patients, and still impact if they were on supplemental oxygen, but did not show that impact. And if anything, a trend towards worsening outcomes if it was started on those that were not yet requiring supplemental oxygen. And so obviously it's, more data needs to come out on this, but the recovery trial and the other trial, US that showed this, I think does not yet speak to the fact of being able to, showing a benefit to giving it early. But I still think it's very interesting to what access is working, that why it has a response to dexamethasone, methylprednisolone, et cetera, but yet not to IL-6 inhibitors.
Thank you.
And the interesting thing here, Francis, is that this is not just related to COVID-19. There is evidence that glucocorticoids will work in acute respiratory distress syndrome of other origins. And again, the evidence is for a good effect late. And I think that is exactly what we don't understand, why late would work, especially in relation to lung damage, which is so sensitive.
Thank you.
I have a question from Elaine Fuchs.
Yes, I have a question and a comment that I'd be curious to know, Salvador and Anne, your thoughts on this. But from our research on skin stem cells and then more recent research on hematopoietic stem cells, it's becoming increasingly clear that exposure to a inflammatory state is remembered by the stem cells. So it's not simply the T cell rearrangements or the B cell rearrangements, but rather an epigenetic memory that is fixed on these stem cells. And in the hematopoietic system, it skews the stem cells so that they don't make as much lymphoid T and B cells, and they make many more myeloid that contribute to the inflammatory state. Additionally, Western diet exacerbates that and shifts them even more to a sustained myeloid lineage, which suggests a reason to me of how how obesity, how exposure to Western diet, and how this cytokine storm can happen because with these exposures, the next exposure is more robust than the previous exposure. And I'm wondering whether that fits into some of the experiences that you've seen with regards to patients.
I don't see patients, but the one thing that we will need to investigate very rapidly is, on top of the profile, the cellular profile and the humoral profile of the systemic inflammation that accompanies all these diseases, in which way the coronavirus impacts that, and in which way the pattern of cytokine and cellular response changes. Because there must be either two patterns of the exaggeration of a pattern which is already there due to these inflammatory diseases like hypertension, like obesity and metabolic syndrome and diabetes type 2 and so on. I think that is the interface that we need to understand, both in terms of cellular response and in humoral response.
Thank you.
All I would say, Elaine, as far as the patient said, if I understand your question correctly, you're wondering as far as the cumulative impact of that from the inflammatory perspective, if you've had that previously. And so is that correct?
Yes, essentially that initial inflammatory experience, if it's a robust one, then causes a skewing, a memory, epigenetic memory inside the hematopoietic stem cell. It skews it to the myeloid fate, which means that the next time around, the inflammation is going to be more robust, and it can come from different sources. People have shown that it doesn't matter what the initial inflammatory response is, so it doesn't have to be COVID, but then when it hits, as if it's cumulative, it would be increasing in aging individuals. People have shown that it increases with regards to Western diet. And so there are all these different risk factors that would explain, to me at least from a stem cell biologist perspective, how you would end up with some patients really severely affected by a cytokine storm, whereas other patients are not going to be as affected.
Yes, no, I think it's very interesting. What I'd say from the patients that I've taken care of that have had these prolonged cytokine storm-like reactions, that often those are ones that have also had prolongation of viremia. And then in doing repeat testing have ongoing or are outside of the typical 20-day time period or so, where you think that then you should no longer have infective virus. And that often those are ones that have had some kind of prior inflammatory underlying mechanism that required them to be on rituximab or something else. And so what we've wondered is it the actual rituximab and those treatments, the anti-CD20 treatments, or is it the underlying disease, such as some recent patient that had antiphospholipid syndrome, for example? So what is it that are we blaming it on the pharmacologics that are being used in these individuals to make them quote unquote immunocompromised, or is it a case of their underlying inflammatory? I don't know the answer to it. I find it very interesting, but yes, we have seen those that have longer seem to definitely have multiple inflammatory prior responses.
I have another question to Anne from Haibu 1.
Yes, actually, I have two questions to Anne. The first is about their publications and ongoing clinical trials on BCG vaccination could render population level protection from COVID-19. So what is the possible immunological mechanism for its protection? And the second, Dr. Tendrous mentioned we are going to have large part of the world population get vaccination. If that is the case, how much we should worry about the ADE, the antibody-dependent enhancement, and what is the possibility of ADE in other vaccination for virus?
Well, thank you for those questions. I'll say they weren't the easiest questions I've been able to answer. I'll try to address them, but I'm sure others also can add to it. As far as the BCG vaccine, I can't speak really very well to what the mechanistic theory of it. I can tell you that we are working on it. That one of the benefits, obviously, to the fact is that you don't have to start with the phase 1 and phase 2 trials. And so the phase 3 multi-center trial is supposed to start in November here for that. And so to get to the more the granular, to answer your question as far as the immunologic reasons for this or whatnot, if I can respond to you offline through an email, I feel like there's a lot of potential thoughts of what we have for this. And the hope is that this would not just be for COVID-19, but that this could be for respiratory viruses. And so that the thought is that it is more of an immunologic response rather than targeted per virus. And so that is our hope, but I can send you some information offline to speak more to it, if that's okay.
Yeah, okay, thank you.
And then maybe someone else might be better equipped to answer your second question as far as you asked about the antibody dependent response that this would then have the virus spread vaccine. In terms
that is the for the audience, that is the effect that some vaccine actually, instead of rendering protection, but actually cause more severe damage to the people who receive the vaccination.
So my understanding is that this is also dependent on the platform of which of the vaccine. And the concern is in the messenger RNA or the nucleic acid platform, that would this be even more so for this? And so I think the problem, or I shouldn't say the problem, the challenge with accelerating the timeline for these vaccinations, and the fact that though still the numbers of individuals that are being enrolled in the phase 3 vaccines are not being sacrificed and are still being at the numbers. The issue really is the fact that it's hard to do this with an underlying pandemic, as far as knowing what the efficacy also that you're trying to get at, because you need to have it be done enrollment in areas that have a high enough prevalence so that you can see disease as well, right, to be able to achieve the certain efficacy. And then what is a long-term follow-up that you need to have to be able to then see if the antibody dependent response of this that have other sequelae, that is usually a longer term thing that is seen. And so, yes, I think that is something that we definitely share as a concern, but I think the other concern is that we don't know how long that response would last. And so that is, I think, a lot of unknowns at this point.
Mr. Chair, may I just pose that question back to Haibo, if I may? Haibo, the genesis of your question comes from the following: that the messenger RNA of the spike protein elicits the DNA of the host to develop an antibody to that protein. And the generation of that antibody may itself be damaging to the host. So do you have experience in China regarding that observation as to the evolution or the emergence of the antibody from the host that then is disabling to the host?
Yes, now we have 11 vaccines has been developed in China for the clinical and preclinical trial, and 4 of them have entered the phase 3 trials. And from the news report from the State Council Information Office, the chief scientist said they haven't observed any SAE or the ADE from the ongoing clinical trial. I understand they have recruited more than 30,000 patients for some of the trials in the phase 3. So no observation yet.
Thank you.
So I see a question by Joachim again to Anne, and then there was a question to Ada from Jose Unushik. So maybe we could have those questions.
Okay, thank you, Chair. Barbara Burman has underlined the key role of having resources in order to get communities treated who have infections in rural Kenya. What can we say about costs of testing, alternative approaches, and costs of vaccinations? Only if we can bring in concerns related to unit costs of testing and unit costs of vaccinations, is it realistic to have the large-scale multi-million treatments? Anne, what can you say about that, or Frank, or Salvador?
Well, in relation to testing, one of the things which is changing completely the panorama in the COVID-19, especially for the low and middle income countries, is the test using the antigens rather than PCR. In countries of low and middle income, the setting up of a PCR machine is actually a big adventure. Sometimes there is no infrastructure, no critical mass, and no information system that allows the reporting of the cases to be anything useful. I think by adopting the antigen trials, which are much, much cheaper, that is going to change the panorama of identifying the spread of the disease and being able to do the contact tracing and the isolation which is necessary. I think that is going to be make the big difference. And you heard from the WHO that they have made available, I think, 140 million tests of antigen for the low and middle income countries. And I think that's going to be very significant. In terms of multi-million dollar treatments and so on, in the case of the pandemic of the chronic degenerative diseases, which is much worse than the pandemic of the COVID, the number of people which is being killed, especially in the third world, by the diseases of the rich world, is enormous now. More than 50% of the cardiovascular deaths and more than 70% of the cancer deaths in the underdeveloped world are due to the fact that these people have a lifestyle which is acquired from the Western lifestyle. So changes in lifestyle probably are much cheaper and more beneficial for everybody than the investment in very expensive treatments.
Thank you. I have a perhaps last question from Mohammed Hassan.
Can Anne respond to that just for a moment? Anne,
sorry.
If I may just very briefly to build on what Salvador said, as far as the testing part and the cost, what Professor Noblick had messaged me about as well during this, that I was remiss in not talking about in testing, is the alternative also to just basic PCR testing, but to RT-LAMP testing, which stands for loop-mediated isothermal amplification after reverse transcriptase. And this allows us to have handheld devices, point of care testing a PCR. So it allows you to get the high sensitivity and specificity in a much more user-friendly way to be able to do mass productions. And so fortunately, there are none yet that are fully approved to my understanding, but there's multiple companies and labs that are working on development of this. And to me, this would be such a great happy medium between the antigen testing and our current PCR platforms, because it would help to decentralize testing from the PCR platforms, but yet have higher specificity and sensitivity, because I worry about the widespread use of antigen testing in certain low prevalent areas, such as we've been talking about in sub-Saharan Africa, for example, that would we then be faced with not only the false negatives that we know we would have that we'd be less concerned about, but the false positives. And what would that then impact from a cost perspective as well, when you think about what you then need to do for contact tracing, et cetera, if it's not real, and then the multiple tests that you need to have. And so I think there needs to be, to me, there is not just one testing mechanism that's the answer, but it has to be multiple ones depending on the type of patient, the prevalence in the area, as well as then the turnaround time and cost.
Stay online, Anne, because there is another and probably the last question by Mohammed Hassan, also to you, Anne.
Thank you very much. A very quick question. A couple of days ago, Indian scientists announced the development of an inexpensive paper-based test for coronavirus, which is based on gene editing techniques, CRISPR techniques. So I'm asking Dr. Ann Woolley whether this sort of testing has any future in the developing countries. The Indian group seems to be very enthusiastic about it. They even mentioned the cost of about $5 per test. So I'm wondering whether this information is now widespread and what the scientific community think about it.
What I can say is that there are a lot of proponents for this paper-based testing that is so inexpensive. They feel you need to get it less than $5. People feel you need to be down to at least $1 so that you can then actually do the repetitive part of the testing that would then be critical with this. But CRISPR-based testing platforms are excellent and have been used and are used in multiple different platforms. So yes, I think that's an advance in the field. And I think with just like the RT LAMP ones, the other CRISPR ones, to me, are really the more novel areas of how are we going to advance this. I believe Professor Noblick wanted to say something regards to this as well.
Yeah, I mean, I just wanted to follow up on what you were just mentioning before. I think those RT LAMP based tests are something that is coming up. I think one thing that we're facing a little bit is that the fact that they are deliberately made in a way so that they get rid of all kind of IP rights and things. Of course, that makes them less attractive for a big pharmaceutical company to actually roll them out because they're cheaper, right? But I think they are coming. I mean, I think there's various groups around the world that have developed them. Some of them can be done with just household equipment, with homemade enzymes and chemicals, and I think they do have great potential, particularly for less developed countries.
So I have no further questions on my question and answer list. If there are further questions, they should come up now, because
I have a question for Ada.
Yeah.
First of all, before I do a question for Ada, I just want to make a comment on Anne's comments about the dangers of the false positives, particularly on when you have a very small percentage of contamination in the area. There's a progression of error there that can be very problematic. And I think it's an interesting topic that she raised about the antigen topics on areas where you have a small amount of disease. Ada, you brought up the issue about drug design, and I think we haven't discussed enough, and I think it's a very interesting one. I'm particularly interested for a few years on your ideas applied to antibiotics, but I think you can apply to other drugs in general. What I like to call allosteric drugs, where you try to bind far from the active sites of the disease. And that creates the number of targets enormously large. I have a couple questions for it. One is, do we have evidence of how these far from active sites antibiotics work, based not on defined drugs, but based on the laboratory? How this is this allosteric mechanism in terms of sort of drug activation? And if you are target sites far from the active site, how do you have sort of side effects by maybe targeting also sites on the human ribosome? Your microphone is off. Ada, your microphone is off.
Now it's on. I'm not so far. I'm talking now. What we know now is that we can attach compounds that we design that are recognizing exactly the size of the piece that we talk about on the surface of the ribosome. Like if it's RNA, it can be antisense. If you know what it is, I'm sure you do. So we produce an antisense with the right, or what we think is the right sequence. And if this piece of the surface is involved in contacts that are important for biosynthesis, for protein biosynthesis, not in the active site, but in contacts with other factors like elongation factors, or between the two subunits, or with the other components of the cell, it stops protein biosynthesis. And we have already 25 of them.
And
Now,
how about side
they
effects?
should-
How
they-
specific are
we
they?
don't know about side effects. We don't know at all. But we know that we can combine them with a penetrating moieties, or even with a fluorescent or chemiluminescent, so we can see that it binds. How it happens with human beings, I don't know. Unfortunately, I'm not allowed to do this.
Okay.
You want to do it, Jose?
Will be interesting.
Send it to you.
I've been thinking about it.
Think about it. If you have an idea, maybe you
Okay.
can do it. Maybe you can find a way to do it, to get into real patients. We'll be happy to collaborate.
Thank you, Ada. Thank you, Jose. Now I think I got to the end of the list of those requesting questions. We are also nicely over time, but it was such a fascinating discussion. I really enjoyed it. I would have had a last question on the cerebral effects, because we see more and more cognitive complications after SARS-2, COVID-2, whether this is purely vascular or whether there's a direct effect on nerve cells. But this is for tomorrow, maybe. So I would like to give the chair back to I don't know, Marcello, are you taking back, or Joachim?
Yeah, I take it back. Thank you, Wolf. Thank you for chairing us so ably. Also, thank you for your very pertinent remarks opening our afternoon session. It is for me to thank our superb speakers, Frank Del Monico, Ann Woolley, Ada Jonat, Salvador Moncada, and Barbara Burman, and all the discussion participants. I want to close by making a few remarks of what I think was standing out. One is the key role of progress in basic science in order to address the pandemic root causes and opportunities for treatment. Secondly, the need for a redesign of health systems, as pointed out by several of you. And third, the attention to the socioeconomic environment and the system change, which exposes the poor, the aged, and the weak more than everyone else. So the inequity effects of the pandemic. While our agenda was and is science for survival, the statements by Dr. Tedros and Pope Francis focused on solidarity. And we should keep that in mind when we meet tomorrow again. We have a very exciting agenda starting again at 2 o'clock tomorrow. If we were in Casina Pio, we would now have a wonderful cup of coffee or tea. We would have conversations, bilateral or in small groups. We miss all that. Then we would have another session and would overrun the time, and then would go downstairs for dinner and continue our discussions. I just want to express my hopes that we will have that, but the atmosphere in this virtual meeting, thanks to your chairing, Wolf, and the focused conversations and discussions, was almost like in Casina Pio. I wish you a wonderful afternoon, evening, or day. Thank you, and see you tomorrow again. Bye-bye now.